speak today about the medical education. Medical education is a big challenge because it is a lot of change. Mainly medical education is about change. And because it is expanding, and the goal of medical education always expanding, so we have to keep on changing with them. So if you change the way you look at things, the things you look at change. So when we change anything, we have an old thing, and we are moving to the new thing. Now, whether the old is right at that time or good or bad, we are not going to discuss it. But it was normal at that time. But what we want is the new one. Any change in life is faced with a lot of resistance initially. So after the resistance, you have to be really patient with it. You'll get apathy, and then compliance, and conformance, and then finally, they will commit with you, and they get commitment. How did we train or make the training in the Kingdom of Saudi Arabia, and how did we improve it? I'm going to take you for a journey to Saudi Arabia for 5 minutes and bring you back to Kuwait. Now, this is a period of 23 years. I started in 1992 when I came back from England and with MRCOG, and I was full of energy. I want to do all the courses which I have seen in my country. So I did the first course, which is MRCOG Part 2 course. At that time, there was only one course in that hospital. No more courses. The administration did not recognize courses. Nobody interested. Nobody wanted. But I was insisting on doing courses. So we did the first one, and that was 1992. 2015, the number of courses in the hospital became 950 courses over a period of 23 years. But this period was full of challenges, struggle, resistance, but on the other side, there was a lot of patience. Finally, we got it. When we became at around 1998, all the other departments, not only obstetric department, all other departments wanted to do the courses. So we had their courses. Almost in 1998, we had 21 courses. In 2007, we started life support courses, and here there is a lot of courses in the same time. And when we reached to 2015, in one day, sometimes we have 6 courses going on in the building. Initially, when we start, we don't have even a room to do the course. And finally, now, if you look at this graph, you will find in 1998, only 21. And here you will find 950 courses. Initially, we trained only 7,936 candidates. And here we reached to 23,000 candidates. Then we had affiliation with all these places. And when CanMed recently came to around 5 years ago, when we had the contract with the Royal College of Canada, we had a lot of workshops over there. Initially, the preparatory courses was mainly the courses of the postgraduate. And then we started to have the life support courses, and when it became mandatory to every resident, no resident should start her rotation as R1 unless she had the life support courses, whether it is for medicine, pediatric, surgery, or OBGYN. Of course, we have a lot of challenges at that time. We had the autonomous structure for decision making, and this was a big challenge because the Ministry of Health was interrupting, and there was a lot of struggle. We had problems of manpower, software, and resources. Now this is our postgraduate center. Initially, it was not even 2 meters, and now look at it. But that came with patience. How did we improve the medical education in Saudi Arabia? I will just go through these in a short time, We trained 3,500 trainees. We had 264 instructors, and we had 24 directors. We had 9 centers recognized for the training in Saudi Arabia, and we had spread out to Bahrain and Syria and Kuwait. We received the Center of Excellency in 2012, and the license, we gave it to Bahrain and to Kuwait in 2011. We introduced basic life support in obstetrics, not only advanced life support in obstetrics for doctors, but we wanted to improve also the nurses. So we introduced the BOLSO, and we initiated the BOLSO in Sudan by request of Sudan. We did research on also, and we had some voluntary work. In Kingdom of Saudi Arabia, we trained, as I told you, 3,000 doctors and 2,500 nurses. Almost every Thursday, we have one course of BLSO. Then we started the course of also as training for mainly, we started, the target was mainly the consultant initially, because once the consultant trained, all the others are trained in the team. Then we initiated a leading team in each city, and we recruited a director for each city, 9 centers, and a faculty of 8 instructors. We concentrated mainly on the labor room staff. Here some of the pictures of the stations where the candidates are trained, and here the centers of Saudi Arabia, which are 9 centers. Here we did the basic life support to nurses. We concentrated mainly on partograms and also on the fetal monitoring, because this is our weak point in there, and that have really helped us. And some of the centers, they did their studies, observational studies, before 6 months before, also 6 months after advanced life support. Here is some of the families of also, and some of the nurses taking their stations. Now in Bahrain, when we started also, we have to go, we have received a request from Sudan, because most of them, they have their deliveries through through midwives. But these midwives, they did not study the midwifery basis. So we went there and we did basic life support for them, and because they have female circumcision, we have done for them the perineal repair, and this was a voluntary from Saudi Arabia. We took it. We made 45 model like that, because the one model, if we want to buy it, is 4,000 riyal. So we took this one, which is only 80 riyal in Saudi Arabia. We took it as a present to Sudan, and all the midwives there, we trained them on this. Here in Bahrain, and this is the Sheikh of Bahrain, Dr. Khalid, and here in Syria, all is voluntary work. Then here we received the Center of Excellency after having all this efforts. Now, how did it improve our practice, the advanced life support? It taught us the teamwork. It taught us the multidisciplinary collaboration. It taught us how to communicate with each other and with hospital. And it helped us in early diagnosis of the problems, and improved the documentation, and improved the nurse-physician relationship. Here, 6 months before also, 6 months after also, for severe bleeding, it was 58 cases. And after also, it was only 26 cases. And here is shoulder dystocia, 6 cases with 50% transient weakness of the as Erb's palsy. And here, after also, they have 9 cases and only 30% transient. In Guatemala, they have also seen the PPH before and after also, and it was 18 and ended up by 8, and 13 and ended up by 4 after also. Here is also an observational study about postpartum hemorrhage in Tanzania. Pre also, it was 168, 92, 45% relative risk reduction. And in severe postpartum hemorrhage, 52% risk reduction. And here the episiotomy also reduced from 60 till 20% in 2 months' time. That is in Honduras. Now, how are we going to improve the training in Kuwait? The training in Kuwait, since I came here in 2015, April 2015. We did 6 courses so far of also, from here till here. This one done is 2011. From here till here, that was done, and 208 candidates was trained. Now, I have to stop here and say a special thanks to Dr. Khalid Najjar and Dr. Fatma Al-Kindari, because at this stage, we have a struggle, because we are just starting, but the person who supported us is these 2 persons. This is some of the stations in Kuwait, and this is the families. We have 6 families now of also in Kuwait. Now, what are the challenges that we have in the training in Kuwait? We have a role of Ministry of Health, role of KIMS, role of program directors, and role of hospitals and as environment for education, and role of tutors, and role of residents and patients. Now, Ministry of Health, they have dissatisfaction with the current education delivery method, and they have the need for healthcare education to recognize and address the ever-growing specialization with the field of medical practice, and the need to keep pace with continually changing educational technology, and the impact of healthcare reform on educational practice, and the continuous change in medical education. It is a matter of a lot of change, and I think Ministry of Health cannot cope with this change. Now, what is the solution? Standardization of healthcare, simulator education practice, providing online education, accepting the continuous change, and training outside the country to bring a new fresh blood, fresh experience. Now, what is the role of KIMS? Establishment of organization structure, which is matching the international structures, like having faculty development office, accreditation office, examination office, and establishment of quality process to review all the rotation, the residency, and the tutors, and improvement of the process of admission and examination and appeal. Initiation of committees like policy committee, credential committee, scientific council, improving the curriculum design and communication plan with stakeholders like Ministry of Health and the civil service commissions, and the KIMS Care conferences. Like in a couple of days, we are going to have the KIMS Care, which is going to be the 4th one. We have until now 1,000 Kuwaiti trainees all over Kuwait. We have 45 workshops done so far, and we have 25 programs going on. What is the role of the program director? Program director have a big, big responsibility. He is supposed to organize, implement, modify the residency program. He is responsible about so many things, administrative and educational things. His administrative role is going to be routinely monitoring resident progress, schedule meeting, procedural logbook, third-party evaluation, portfolio for the residents, resident promotion, graduation, ensure the quality of the teaching faculty, and ensure the teaching faculty are committed to supervision with the graded responsibility. And I feel sometimes sorry for the tutors also, because they are senior person, and all of a sudden, because of their seniority, they are supposed to be teacher, but they did not receive the right workshops for teaching. So they are going, inshallah, this has been discussed, and they are going to receive a lot of teaching so that when they hold the group of residents, they will know what is the way and how to guide them. Educational role for the program director to facilitate resident participation in education and to ensure that each resident develop a personal project learning to foster continued professional growth and involve the resident in their education and help the residency program committee. How can he be a good leader? He will be a good leader if he supports the resident, if he encourages the resident, if he stimulates the resident to work, if he recognizes their experience, if he inspires them, if he has a clear vision and a clear goal, and he leads these residents to the goal. He's not going to be boss on them. He's going to be a leader. And the leader is one of them, but leading them, and they are following him from their heart because they think that this is the example. The leader is one who knows the way, who goes the way, and who shows the resident the right way. Because the leader has a clear vision and a clear goal, he can make all the residents following him with a clear goal. And that's what we want, actually. We want the resident to have a clear goal while they are walking, while they are training. In their journey of training, we want them to have a clear goal. What does it mean, clear goal? I want to do a cesarean section. I want to be excellent. No, this is not the goal. The goal is to be medical expert. You are going to be the best in all the parameters of education. Emotional intelligence. Emotional intelligence, if you have it, you have the feeling how to feel for the others. So if you have this feeling, you can motivate these residents according to the way you want. And you always, the way you want as program director is the right way. If you see the importance of the EQ, emotional intelligence, is almost 3 or 4 times the IQ. What is the benefit if the program director is excellent, he is expert, he is very intelligent, but he doesn't have emotional intelligence? We need it for emotional. We need the emotional intelligence for the leader, any leader. Leaders become great, not because of their power, but because they can empower the residents or empower the others. To be inspired is great, but to inspire others is incredible. What is the role of your resident? The role of the resident is empowering the program. We have to see your enthusiasm. We have to see you are meticulous and really serious. And you have access, as long as you have now what you have, we didn't even dream of at our age. Because you have a lot of access to the information technology. In 1 minute, you can get everything. At that time, we have to go back, and we have to go through the books and come back again. You people now, in 1 minute, if there is any question mark, immediately you open your iPhone and get it. Well-structured program curriculum, and you have research accessibility, but they need closer guidance, they need interested tutor, and they need educational environment. And I tell you, you are the one who is going to create this environment. It is in your hand that you make the environment full of gossip, or you make the environment full of knowledge. It is you who create it for yourself. E-learning is very, very in the hand of everybody now. So what is the role of the tutor? As I told you earlier on, I sometimes feel sorry for the tutor, but even though...
Dr. Adla, you have 2 minutes only.
Okay. Helping in the development of the whole directive of the curriculum and providing supervision and feedback, assessment and examination, and the collaboration with the program director. What is the role of the environment? Encouraging and supporting the resident, and they have to accept faculty acceptance and be comfortable with the technology and maintaining the high standards and providing them with the skill they need. And they have to accept the changes. Well, is there any role for the patient? Yes, the patient have a role also. We can evaluate the resident on the professional attitude and empathy on the patient. We have to see you, how are you going to build a rapport with the patient? And the patient can be also a role player. Medical education is not about how to learn medicine. It's about to learn how to learn medicine. Now, if you are, actually, we don't want you only to transfer information to you. We don't want a transmission of information to the resident. We want to transform the resident. How are we going to transform him? He has to be professional, communicator, collaborator, leader, health advocate, and scholar, so that he will be medical expert. So what is the key? The key is to accept change. Thank you very much.